Hello, my name is Henry Silverman, and today I would like to talk about the ethical principles guiding research involving children. The specific topics I'd like to talk about today include the vulnerability of children and hence the need for additional protections for children, which include scientific necessity, the appropriate balance of risk and benefits, parental permission, and finally, child assent. Now, vulnerability of children could stem from a number of factors. One, children commonly lack mature decision-making capacity. They are subject to the authorities of others. They may differ in ways that can mask underlying dissent. Also, their rights and interests may be socially undervalued. They may have acute medical conditions requiring immediate decisions without adequate time for education and deliberation. And finally, they may lack important socially distributed goods that would be provided as a consequence of research participation. Recognition of this vulnerability has led many countries to develop regulations or guidelines specific to research with children. Based on recommendations made by the National Commission in the U.S. back in the 1970s and early 1980s, regulations were developed in 1983 that governed research involving children. These are known as Subpart D. The additional protections for children to be enrolled in a research study can be divided into 4 nested domains, with each protection building on an adequate response to the prior protection. For example, the enrollment of children in a research study must first be considered scientifically necessary before the evaluation of whether the research intervention presents an appropriate balance of risk and potential benefit. Once there is appropriate balance of risk and benefit, one goes on to assess the role of parental permission and whether one needs child assent. A fundamental pillar of pediatric research is the ethical principle of scientific necessity. This principle holds that children should not be enrolled in a clinical investigation unless absolutely necessary to answer an important scientific question about the health and welfare of children. U.S. regulations also require that risks to subjects are minimized by eliminating unnecessary procedures and that selection of subjects must be equitable. Equitable selection requires that subjects who are capable of informed consent, for example, competent adults, should be enrolled prior to subjects who cannot consent, for example, children. There is broad international agreement on this approach. Assuming there are no significant scientific reasons to enroll younger children preferentially prior to older children or adults. Next, I would like to talk about the appropriate balance of risk and benefit, which is different from what we're seeing with adults. Again, I want to emphasize that with adults, we're looking about risks being balanced to any potential benefits to subjects themselves and the importance of knowledge that may be reasonably be expected to result. As we saw with adults who are subject to research procedures that has the potential of direct benefits, when the net risks were calculated, one has to ensure that these net risks are not excessive. Regarding research-only procedures, in other words, procedures that had no potential for direct benefits, one has to make sure that these risks are reasonable to the knowledge to be gained. As we shall see with children, the net risks from procedures that has the potential for direct benefits has to be 0. Now, regarding risk and benefits, the additional safeguards for children enrolled in research are based on 2 ethical principles. First, the risk to which children would be exposed must be low if there is no prospect of direct therapeutic benefit to the enrolled children. Second, higher risk must be offset by appropriate compensatory benefit. Hence, research involving children must demonstrate either an acceptable low risk or a sufficient prospect of direct benefits to justify the risks of the intervention. Now, the current regulatory guidelines for pediatric research defines 4 levels of risk in research, each of which is subject to a different level of regulation and oversight. So in the next few slides, I'd like to discuss these 4 different risk levels. The first one, which is 46.404, involves research not involving greater than minimal risk. It says, research will be allowed when the IRB finds that no greater than minimal risk to children is presented, and if adequate provisions are made for soliciting the assent of the children, when appropriate, and the permission of their parents or guardians. Studies that involve only minimal risk can be performed even if they do not offer any prospect of direct benefit to the research subjects. Again, I want to emphasize that studies involving minimal risk could involve healthy and non-healthy children alike. As we saw in our previous modules, there is some controversy regarding what is minimal risk or what is normal or routine risk. Well, the National Commission in the late 1970s defined minimal risk as those risks normally encountered by healthy children. Now, this specific language regarding healthy children was not included in the definition of the subsequent U.S. regulations. However, most ethicists and federal panels agree with the interpretation being anchored by healthy children. Other things to consider is that the administration of an experimental product is neither routine nor minimal risk, and procedures that do not present a prospect of direct benefit must present a low risk, meaning either minimal risk or a minor increase over minimal risk. The second level of risk is for research involving greater than minimal risk, but presenting the prospect of direct benefit to the individual subjects. Essentially, if more than minimal risk to children is presented by an intervention or procedure that holds out the prospect of direct benefit for the individual subject, the research will be allowed only if the IRB finds the following. 1, the risk is justified by the anticipated benefit to the subjects. 2, the relation of the anticipated benefit to the risk is at least as favorable to the subjects as that presented by available alternative approaches. And 3, adequate provisions are made for soliciting the assent of the child and permission of the parents or guardians. Now, implicit in the ethical conduct of studies that are in this risk category is the assumption of clinical equipoise, as the relation of the anticipated benefit to the risk must be at least as favorable to the child as that presented by alternative available approaches. Essentially, the risk-benefit ratio of the procedure must be similar to that of alternative approaches, and this also means that the net risks are 0. There cannot be any positive net risks with procedures that has the prospect of direct benefit to the child. The next risk category is 46.406, which involves research involving greater than minimal risk and no prospect of the direct benefit to individual subjects, but likely to yield generalizable knowledge about the subject's disorder or condition. Research is allowed only if the risk represents a minor increase over minimal risk. 2, the intervention or procedure presents experiences to subjects that are reasonably commensurate with those inherent in their actual or expected medical, dental, psychological, social, or educational situations. 3rd, the intervention or procedure is likely to yield generalizable knowledge about the subject's disorder or condition, which is of vital importance for the understanding of the subject's disorder or condition. And finally, adequate provisions are made for soliciting the assent of the child and permission of the parents or guardians. The justification for this classification has included that the increased risk is warranted due to the scientific necessity of obtaining generalizable knowledge of the subject's disorder or condition. The procedures are commensurate with those in the child's actual or expected medical, dental, psychological, social, or educational situation, and that the risk of harm is just slightly more than that permissible for other children. That said, we need to explore certain concepts that are in this risk category. Essentially, what is meant by a minor increase over minimal risk? Second, what do we mean by experiences that are reasonably commensurate with those inherent in the actual situation of the child? What is the purpose of 46.406B? And then third, what do we mean by a subject's disorder? And more importantly, what do we mean by a subject's condition? Well, regarding the minor increase over minimal risk, as defined by the National Commission, a minor increase refers to a risk which, while it goes beyond the narrow boundaries of minimal risk, poses no significant threat to the child's health or well-being. Given this conservative limit, the promise of substantial future benefits to children other than the subject does justify research which goes beyond, but only slightly beyond, minimal risk. So, how do you operationalize this definition of minor increase over minimal risk? Well, the best way to understand this abstract risk category is to compare it to certain procedures that might constitute a minor increase over minimal risk, and the conceived wisdom includes the following examples of procedures. For example, urine collection via a catheter, a lumbar puncture, a skin punch biopsy with topical pain relief, or a bone marrow aspirate with topical pain relief. Now, what we mean by reasonably commensurate? Specifically, what is the reason for 46406 subpart B? The intervention or procedure presents experiences to subjects that are reasonably commensurate with those inherent in the actual or expected medical, dental, psychological, social, or educational situations. The National Commission explained that the reason for this provision is to assist children who can assent to make a knowledgeable decision about their participation in research based on some familiarity with the intervention or procedure and its effects. The IOM has given an opinion that the research procedure need to be reasonably similar, although not identical, to the procedures that prospective research participants may ordinarily have experienced. The goal here is to make the research procedures to be experienced as tangible as possible in order for the parents to provide permission and the child to provide assent. Lastly, what do we mean by a subject's disorder or condition? According to the regulations, children may be included in these no-benefit, higher-hazard pediatric studies if they had a disorder, which really means an actual disease or illness, but they may also be enrolled in these types of research study if they just have a condition. Well, because almost any state of being could be described as having a condition, controversies have existed for decades about what this definition includes or excludes for the purposes of enrolling children in this third risk category of no benefit and higher than minimal risk research. Well, the Institute of Medicine has weighed in, and they defined the term condition as referring to a specific or set of specific physical, psychological, neurodevelopmental, or social characteristics, and let me emphasize the word social, that an established body of scientific evidence or clinical knowledge has shown to negatively affect children's health and well-being, or to increase their risk of developing a health problem in the future. Therefore, a child could be healthy, but at risk for the condition that is object of the research. Now, the National Human Research Protection Advisory Commission interpreted condition in this following way. We interpret the concept of disorder or condition as relating to a specific characteristic which describes a group of children, a physical, social, psychological, or neurodevelopmental condition affecting children, or the risk of certain children developing a disease in the future based on diagnostic testing or physical examination. So, for example, prematurity, infancy, adolescence, poverty, living in a compromised physical environment, institutionalization, or having a genetic predisposition to future illness are some of the disorders or conditions of children that can, under the appropriate circumstances, warrant permissible research that presents levels of risk that are a minor increase over minimal risk without the prospect of benefit. Now, Dr. Kopelman finds these definitions problematic because each includes people's social characteristic as a possible way to justify no-benefit, high-risk pediatric studies. The meaning of the term social is extremely inclusive, and she has concerns regarding, first, it's problematic from a scientific point of view. For example, the link between poverty and obesity. Well, one could say that anyone in poverty is at risk for developing obesity. However, that is not scientifically correct because it's not the poverty per se that leads to obesity, but rather inadequate nutrition. So one would want to study the effects of inadequate nutrition and how it relates to obesity. Also her concern that it would be unfair to enroll because of social characteristics. Essentially, these children with these social characteristics, such as poverty or institutionalization, those children would bear disproportionately the burdens of research due to social situations that can be generalizable to other classes of children. In other words, the other classes of children would gain benefit from research done on children who have these social characteristics. When you're thinking about this, think about the Willowbrook experiments and whether those children, because of their social situation and hence their risk for developing hepatitis, would then be permissible to be enrolled in research under this concept of a subject's condition. Kopelman offers this definition of condition: a condition more broadly than a specific disease, but to a specific set of physical, psychological, neurodevelopmental, or social characteristics that have been shown to affect children's health and well-being, or their risk of developing a health problem in the future. The definition of condition can include a genetic or familial predisposition to a future illness, or even a social circumstance that has been linked to a potential deficit in future health, as long as the investigator can substantiate that there is an established body of evidence to support that association. Now, the fourth risk category, 46.407, involves research not otherwise approvable under the previous three risk categories, which present an opportunity to understand, prevent, or alleviate a serious problem affecting the health or welfare of children. When one is dealing with this type of research, the Secretary, after consultation with a panel of experts in the pertinent disciplines, for example, science, medicine, education, ethics, and law, and following opportunity for public review and comment, has determined either that the research in fact does satisfy one of the three previous conditions, or the following. 1, the research presents a reasonable opportunity to further the understanding, prevention, or alleviation of a serious problem affecting the health and welfare of children. 2, the research will be conducted in accordance with sound ethical principles. And 3, adequate provisions are made for soliciting the assent of the child and the permission of the parents or guardians. Now, this fourth risk category is the most complex and the most unusual. It is for studies that involve more than a minor increase above minimal risk, no prospect of direct benefit to the child, but that are judged to be so important in terms of the knowledge that they might yield that they ought to be conducted anyway. Studies that meet these criteria must be likely to yield knowledge that will prevent or alleviate a serious health condition in childhood. I would like to apply some of the points we've been discussing in the last 10 minutes to the use of placebo controls in pediatric research. Since the risk of placebo administration itself is no more than minimal risk, accordingly, the overall risk to the placebo group arises either from withholding known effective treatment, if standard of care is available, or from the research-only procedures that is being done in the research. Placebo administration does not offer a prospect of direct benefit to the enrolled child, so essentially we're dealing with research that does not offer the prospect of direct benefit to the children randomized to the placebo group. Hence, the risk to which a placebo group is exposed must be restricted to minimal risk if the children are healthy, or no more than a minor increase over minimal risk if the child has a disorder or a condition. Lastly, I'd like to say a few words about parental permission and child assent. Parental permission regards an agreement to the participation of a child in clinical investigation. The purpose of parental permission is to protect the child from assuming unreasonable risks. Could parental permission be waived? Well, the U.S. federal regulations allow for a waiver if an IRB determines that the requirement is unreasonable. And 2, according to the FDA, a waiver is permissible only for emergency research. Now, when do we need parental permission if a waiver has not been allowed? Well, that really depends on whether we're dealing with a child. So we have to have an understanding of a definition of a child. And this means children are persons who have not attained legal age for consent to treatment or procedures involved in clinical investigation under applicable law of jurisdiction, meaning the local law of the study site, or in the U.S., we're talking about the laws of the state. So, for example, if a state law has a definition for an emancipated minor, then if a child is considered to be an emancipated minor, parental permission is not warranted. Regarding child assent, that refers to an affirmative agreement to participate in research. Mere failure to object may not be construed as assent. In other words, if a child does not dissent, that does not mean that the child has assent. We're talking about an affirmative agreement to participate in research. The IRB shall determine, according to U.S. regulations, the adequate provisions for soliciting a child's assent, and also the IRB shall determine when a child is capable of providing Assent, which would involve the age, the maturity, and the psychological state of the child. Now, it's very controversial regarding what age could a child give assent and what amount of information should be given a child to provide assent. So, on one hand, if we expect the child to make an adult-like judgment of the risks and benefits and other aspects of the research, such a capacity may not develop until mid-adolescence. On the other hand, if a child simply needs to agree based on their own perspective on the acceptability of the experience, for example, pain of having blood drawn, then a younger child would be capable of assent. Many guidelines have given the opinion that children as young as 7 years of age are capable of assent, depending on what is determined the amount of information that is necessary to be given to the child. Assent may be waived if the capability is so limited that the child cannot be consulted, or the prospect of direct benefit important to the child's health or well-being available only in the research, or 3, minimal risk research that is otherwise is not feasible. So, to sum up what we have just gone over, the basic ethical framework for the additional safeguards for children enrolled in research is widely accepted throughout the world. An intervention that does not offer a prospect of direct benefit to the enrolled child must be no more than low risk, either minimal or a minor increase above minimal risk. The research must be restricted to minimal risk for healthy and non-healthy children. One could broaden minimal risk to minor increase only if scientifically necessary for a child with a disorder or a condition. And the risk of an intervention that is not low must offer the enrolled child a sufficient prospect of direct benefit to justify that risk, and the balance of risk and potential benefit must be comparable to available alternatives. Thank you very much.